When a 41-year-old woman was diagnosed with breast cancer, her medical team followed every modern protocol to remove the disease. However, the post-operative results were devastating. The surgeon had cut directly through the center of the tumor, leaving active cancer behind in the patient's body. Technical skill and surgical equipment worked exactly as intended. Instead, the medical team was deceived by a microscopic optical illusion. Based on the initial biopsy, the team believed the patient had multifocality, a condition where the cancer exists only as small, isolated, and highly manageable dots. Treating the disease as a collection of separate, manageable points left the surgical team unprepared for the reality of the cancer's true footprint. To understand how the medical team was misled, we have to look past the macroscopic view of the surgery and zoom into the cellular environment of the breast tissue. Pathologists often assume these cancer cells are sitting passively inside the patient's existing ducts, a condition frequently labeled as DCIS, but the cells are actually far more aggressive. They actively break through the duct's protective basement membrane to carve out their own pathways through the tissue. This process is called Neoductgenesis. The cancer acts as a rogue factory, building haphazard, newly formed ducts to expand its reach. The cancer then armors these new ducts with a thick layer of fake fibroblasts, the desmoplastic reaction, and surrounds them with dense rings of immune cells. The cancer operates as an active construction site, building a heavily fortified infrastructure throughout the tissue. The core misunderstanding begins when these samples are processed in the pathology lab. To view tissue under a microscope, technicians slice it into incredibly thin 4-micron sheets, reducing a complex 3-dimensional environment into flat 2-dimensional planes. This diagram shows what the pathologist sees on those 2-dimensional slices, a series of disconnected circular rings of cancer cells. Because these circles appear separate on the slide, the pathologist identifies them as isolated tumors and logs a diagnosis of multifocal cancer. But rotating the perspective reveals the true physical space of the tissue. The rings that appeared isolated are actually cross-sections of side branches, all feeding into one single, continuous central duct. The diagnosis of separate tumors is a geometric error that hides the cancer's existence as a single, contiguous web. When this 3-dimensional reality is ignored, the consequences return to the operating table. Because the pathology report for the 41-year-old patient claimed the cancer was just isolated dots, her surgeon performed a conservative, skin-sparing segmentectomy. This decision overlooked the patient's MRI results, which had already signaled that the disease was extensive and widespread. Making a small, restricted cut into a massive, interconnected web makes it nearly certain the scalpel will slice through the cancer's branches, leaving the disease behind. Defeating this disease requires doctors to look past 2-dimensional shadows on a slide and account for the cancer's true 3-dimensional geography.